Good morning or good afternoon to everybody. Interesting topic for this lecture is RDS to COVID, a new entity, and I think this has been a big debate in our intensive care about this topic. And of course, I will present my point of view. Now, let's see first ARDS. ARDS is a syndrome that we invented. Is a syndrome means we have a gas exchange, a mechanics and hemodynamics problem, which derive from a very small lung volume that we call a baby lung, which derive from a very different etiology, pneumonia, sepsis, inhalation, etc. Now, if you take whatever database on a classical RDS, or you take all the studies from which randomized trial, from which our knowledge of RDS and our therapeutic approach of the RDS has been drawn, you see that it's done 80% more or less from pneumonia, bacterial pneumonia, and sepsis. About 50, 30, 40, 40, something like that. That means one thing, that whatever we know about RDS derive from a population in which other causes of RDS, which is just bilateral infiltrates and hypoxemia, the different causes from pneumonia and sepsis are very rare. Now, if I take a COVID-19 pneumonia, is a bilateral hypoxemia, bilateral radiography involvement? Yes, because we start with the ground glass and so on. And this disease, not a syndrome, is equal everywhere. At the beginning, is the patient with severe hypoxemia? Yes. Bilateral infiltrates? Yes. But is a classical RDS? This is the problem. Because if it's not a classical RDS, it's a different entity, to use the same criteria, typical example, the PEEP according to the FiO2 PEEP table of NIH, developed by NIH, makes sense or not. So it's not just question of semantic, it's a deep question of treatment. And I speak overall about the early COVID pneumonia, because in the late stage, the things may change. ARDS. ARDS, as I told you, is a quite typical condition in which we have part of the lung here, which is reduced, is ventilable, is reduced, and sometimes at the dimension of the lung of the baby. That means half a liter, 1 liter, severe RDS, 400 milliliters. This small lung volume is a typical of classical RDS, which I repeat for the third time in 5 minutes, derived from bacterial pneumonia and sepsis. And this is the amount, the little amount of normal lung that we have in RDS, classical RDS. A great part of the lung is out of business, is white, is consolidated or atelectatic. That means pulmonary units full of something else, or pulmonary units which are collapsed under the gravity. And typical, if severe RDS or classic RDS, is the compliance. And you see here, this is the percent of the ventilatable lung. When we have about 20 of compliance, only about 20% of the normal lung is still okay, is still ventilable. That means the RDS, the compliance is a measure of the lung size, the amount of gas that we have into the lung. So low compliance, low amount of gas in the lung. In COVID, I could anticipate at the beginning, the compliance pretty high. And that means the gas volume should be pretty high. Classical ARDS, supine position, you see, look at the dorsal atelectasis, the dorsal density completely disappear. We don't have many data about the CT in prone position. We have 3-4 papers, no more, but all are quite consistent in reporting in early ARDS this kind of phenomenon. And why? Because in early ARDS we have an increased lung weight, the ARDS behave as a sponge, the lung weight is maybe double the normal, or 3 times the normal, may arrive to 3 kilos, 4 kilos instead 800 grams of 1,000 grams, and the lung collapses on its own weight. So, what about COVID? COVID will change the scenario. First, COVID is a disease, specific disease, which may stay under the umbrella of ARDS, but present with completely different characteristics. As an example, at the beginning, when we enter in the emergency room, a lot of people, even with FiO2, PO2, FiO2 extremely low, they come without any real dyspnea. They have a silent hypoxemia. And you see this patient in which we have some ground glass density, and they breathe without any problem. They don't feel any desire, any, we call fame d'aria, hunger of gas. Why they are not dyspneic? You know, the dyspnea is just a sensation, a personal sensation. When you see, you want, your brain desire for a given effort a certain degree of feeling. So I expect 1 liter, I make an effort for 1 liter, I get on 1 liter, and I'm happy. If I make an effort for 1 liter and I get 500, this is problem, and this is called dyspnea. At the beginning, this patient have quite good compliance. There are not great density into the lung, some ground glass opacity, and so many of them are not dyspneic. So we have a hypoxemia without lung collapse, because the lung is full of gas. We have an increased respiratory drive, also for undetermined factors, and we have a great increase in tidal volume. All these patients, typical number, they arrive in hospital with 33 of compliance, and the tidal volume is supposed to be sometimes up to 2-3 times normal. And these are the first, with Professor Cumerlo, who collect this data. You see about 50% of the patients do have a compliance greater than 50, which is not bad, despite a tremendous hypoxia with a shunt fraction greater than 30%. In all my experience, before we grow up with ARDS, in 45 years, 50 years of ARDS, I saw in severe ARDS so frequently a good compliance. The problem is not the compliance alone, but the association between very good compliance and very bad gas exchange. And some colleagues of mine say, okay, no, but the compliance is exactly the same. As an example, this is a paper on Lancet on pathophysiology of COVID, and they say at the end, ARDS and COVID are exactly the same. The compliance, no problem. Now look, in the supplementum, as usually, COVID-19 ARDS, almost 300 patients, compliance 40, classic ARDS 28, pneumonia 28. Between 28 and 40, 12 points is an enormous amount in terms of compliance. And this 103 non-intubated emergency patient, PO2 and FiO2 180, ARDS, maybe in ARDS, yes, maybe in ARDS. Look at the total gas volume. The mean, the median is 2 liters. Here, patients in intensive care, PO2 and FiO2 lower, the mean is close to 2 liters. Where is the baby lung? These are full of gas. Here in green, we have the gas space. How can I treat this patient as they would have a real baby lung? And of course, the compliance, respiratory system compliance, and the gas volume as 35 years data are exactly the same. They are strictly associated. Look here, these are 32 patients with bacterial pneumonia in green, with PO2 and FiO2 180, if I remember correctly, 100, were matched with 32 patients with COVID with the same low PO2. Look here. This is the sternum going down to the vertebra. At each lung level, the gas volume is almost double. So the problem, ARDS, classic ARDS, is alveolo-centric. Here is endothelium-centric, the problem. And we have, at the beginning, loss of vasomotor tone, vacuum mismatch, hypercoagulation, thrombosis. So we lose the control of perfusion. And the deep hypoxemia is due to the VA-Q mismatch. The ventilation goes in one side, and the perfusion goes in another side. We lose the match, which makes our respiration usually normal. This is typical here. Look here. In the classical ARDS, bacterial ARDS, these regions is hypoperfused because we have still some hypoxic vasoconstriction. In COVID, these regions is hyperperfused. And these which appear good, completely without any perfusion. This is the ventilator perfusion mismatch. And this is the main cause of the tremendous severe hypoxia we found in this patient. So in early syndrome, we have severe hypoxia, flexible lung, very compliant, dissociation between CT and hypoxemia, and with disease progression, we go through towards the classical ARDS. Look here, this is quite early COVID, supine 5, prone 5, supine 35, the same patient. Your recruitment, you have some recruitment with people, with 35, and you see about 8% of recruitment. In the prone position, as typical, you have some redistribution of density. You have some clearing here and some formation of density in the ventral regions of the lung. Now, look this one. This is a patient already in intensive care after about 10 days, some of the second week. And you see you have a tremendous density here. And you put in prone position, you have clearing as in classical ARDS. And back in supine during recruitment, 40% of recruitment. Great. So PEEP is indicated here, probably yes. Now I have still COVID, and look here. PO2 and FiO2 80. I put in prone 81. I put in recruitment 76. Look the density. I put the density here. They stay up. That means the nature of the density changes. These are consolidation. That means fibrosis and so on. Pulmonary units full of something, not atelectasis. And no atelectasis, no response to PEEP. Look at the recruitment here. Supine 5, 35, recruitment 0. In about half of the patient in COVID, depending on the time of observation, you may have that during the recruitment maneuver, the PO2 and FiO2 goes down, not goes up. So don't ask what is the PEEP to be used in COVID-19. Doesn't make any sense, this question, unless you specify early stage, intermediate stage, or late stage. And when we proposed two phenotypes, but we propose as a water conversation, not as a dome. I call Professor Chiumello, Professor Camporoda, and say, well, we have one L patient, and immediately they realize is a patient, usually in early stage, with some ground glass, in which the elasticity is low, that means the compliance is high. The VQ mismatch is bad because the hypoxemia is profound. The lung weight is not greatly compromised. Now, if this patient starts with non-invasive support, okay, and we see how the patient reacts. If the patient starts to, despite the support, to have a big inspiratory effort, we have the risk of a self-induced lung injury, plus the virus, the normal progression of the disease. At the end, we have a sort of late ARDS. So depends the treatment and which stage I look at the patient, and at which stage is physiopathology. This was a friend of mine that 95 PO2 and FiO2, all CT, okay, just a little bit of density here. After 1 week of spontaneous breathing, CPAP, mask, knee, and so on. PO2, 80. Look at the CT scan. This is out of business. I mean, would you treat this patient like this, in this condition as here? Now, very often patients in this condition are treated with 10, 15, or even 20 of PEEP. Results, renal failure, death. Remember, the death for the same disease in intensive care, depending on intensive care, goes from 20 to 80%. Treatment counts. So the type L, just a very few suggestions. Non-invasive support, if effort persists, mechanical ventilation. And I would not hesitate to use in lungs like this 7 up to 8 of tidal volume per kilos to prevent hypercapnia, to prevent hyperventilation, to prevent reabsorption atelectasis. Prone position, the PO2 goes up. But if we have 20 patients like this, it makes sense to put all the nurses to change the position of the patient to have just some cosmetic effect on PO2 without any reason why the prone position would improve the survival here, because there is not the prerequisite of the prone position to work, which is excessive strain, better distribution of stress strain. Here, stress strain are near normal. Here is different. Tape H, we may have the classical ARDS. So, and I go to conclude. Having said this is a very bad disease in some patients, because in many others, maybe stop at certain level of the problem, and but in a patient that continue with this disease is really a big problem, also for the late COVID and so on, but this is not my topic. And if I had to summarize my possible suggestion or increases, I see that start the ARDS, we start with atelectasis and recruitability, the same thing, atelectasis and recruitability. Very low, that goes up with the time. And with the time, we have a change from atelectasis down to fibrosis. And the PEEP response decreases. It's 0 here and decreases here. We have the PaCO2 and the consolidation goes up. And the rise in PaCO2 means structural changes in the lung structure. And here we have, in the meantime, we go down with the compliance, or increase the elastance, and the oxygenation stay exactly the same along the course. But here is mainly due to the AQ problems. Here, I think the problems of the true shunt becomes prevalent as in classical ARDS. I thank you for the attention.